Hello, my name is Christina Nussbaum. I'm Chief Revenue Officer here at YWCA Northeast Indiana. By now you've probably noticed we use the word persimmon in a few of our initiatives. We had Power of Persimmon and now Dash of Persimmon, and we even have Persimmon Pride, which is our cultural mantra here at YWCA Northeast Indiana. So what does persimmon represent? It's like, do we love the fruit? Well, of course we do. But it really is the orange Pantone color of our brand. So when you hear the word or read the word persimmon, persimmon represents YWCA Northeast Indiana. So let me talk to you today about Dash of Persimmon, our newest initiative. The Dash and Dash of Persimmon represents the here and now. So what we do for the individuals that we serve is we help them, take them from some point in the past. They've endured addiction, domestic violence, or sexual abuse. We help them with our services in the here and now to move them from the past to a future that's a healthier future for them. So for the individuals that we serve, the Dash represents the YWCA Northeast Indiana. So what is Dash of Persimmon? Dash of Persimmon is going to bring to you several episodes. There's going to be one a month, in which we highlight knowledge brought to you by various different experts throughout our community. And they'll speak on a variety of different topics, but what we hope is the information provided in Dash of Persimmon will help move some individuals from the past to the healthier future, and it will provide you with just a greater knowledge of information on that topic. So we hope that Dash of Persimmon will sweeten your cup.
So in psychiatry, we use criteria to diagnose illnesses or diseases. So like depression has some very specific criteria to classify someone's having a major depressive disorder or having generalized anxiety or generalized anxiety with panic, the words that people are very familiar with. And I don't think anyone would ever argue that those aren't medical conditions. When it comes to substance use disorders, and technically it's and related disorders because it includes at least one behavior which is problematic, gambling, some other ones are being studied, internet gaming, those kinds of things, but they all have the same kind of criteria that makes them different as an illness versus merely a moral choice. One of the criteria is using a substance or behavior longer than you planned, or larger amounts than you planned. Another one is trying to cut down and being unsuccessful. Another one is a failure to participate in activities that used to be really important: social, job, relationships. Negative impact on relationships is a criteria. Inability to carry out your roles like parenting children or being a responsible member of a work group or your family. And then what's really unique that divides a substance use disorder versus someone who merely uses a substance is having cravings for a substance, having tolerance, or it takes more to get the same effect, and then withdrawal symptoms, that when the substance or behavior is drawn away, that there's a classic and kind of medically described withdrawal symptoms. Just like asthma has a great deal of criteria that we classify different kinds of asthma, heart disease, diabetes, clearly, substance use disorders have the same one. And like chronic illnesses, they respond really well to a combination of interventions. Medicines often is one. Clinical interventions for substance use, and most of psychiatry, those interventions are individual group therapy, living in a supportive housing environment, those kinds of things. And then education. And education to everybody who's affected. So if a 10-year-old was diagnosed with diabetes, the 10-year-old would get education, the family would get education. So for that way, it's as the criteria or the diagnosis is the same as any other medical disease, and the interventions or the treatment are the same. Sometimes I like to explain that if I took 10 people and I lined them up and I exposed them all to a substance, let's say opiates, statistically 8 out of 10 would either have a negative response, nausea, itching, that kind of thing, sedation, and say, no thanks, I'll take Tylenol. But the rest of them would be able to say, okay, I was taking opioids because of pain. The pain's gone, I'm out of the hospital, I've recovered from surgery, and I'm going to stop. Statistically, though, 2 people will have a different experience, which is different than your typical. We think opioids as being something that makes people tired, that it sort of a depressant, where most people with an opioid use disorder will experience what we call euphoria, or a sense of wellness, or ease, and that when the reasons for using the opioids are gone, then they'll continue on doing some things to continue getting exposed to that. The brain has a pleasure center where everything that is pleasurable to us, eating, sex, holding a brand new baby, being around family, all those things cause an increase in endorphins. And opioids do that also, just to the degree of what they do or don't do. The problem is when you experience that euphoria, what happens is the brain, at the most primitive level, like the area we share with salamanders and earthworms, not the part that helps us make good decisions, but the other part says, that was a good feeling, I have to experience that again, or I'm not going to be okay. That's why sometimes when people have a substance use disorder, the measures and the lengths that they'll go to satisfy that inner craving seem on the outside to be ridiculous, and they cannot, and people around can't understand. The person who's affected sometimes can't understand why my higher order of brain, the part that's been conditioned by my upbringing, by my exposures, by my structure that I've grown up, says that taking my grandmother's medicine is wrong. The other part of my brain, the more primitive part, says it's necessary. And then that's when all these character, some people call them defects, really they're just coping mechanisms to be able to rationalize, she doesn't need it, I need it, minimize, it's just a few things, that kind of thing. From the outside, that just seems ridiculous, but from the inside, and again, the patients I take care of, it makes perfect sense in the moment. So when someone is affected by a psychiatric illness, whether it be a mood disorder, a thought disorder, or substance use disorder, we look at it and say, what is the most likely interventions, again, a combination of medical, clinical, and changing the environment. What are the most likely interventions that are going to improve their quality of life, improve their impact on their society, and make them a contributing member, and then also, sometimes at the very little, to reduce the likelihood of death. Again, these are progressive, relapsing, remitting illnesses and stuff, much like asthma, diabetes, heart disease, that kind of thing. So I always say that I would never argue with, I think AA has been around for 130 years now, and those principles are very ingrained in treatment of not just substance use disorders, even though that's what they're commonly referred to, but as people in 12-step programs will say, being able to live life on life's terms. And so those principles of the 12 steps and the camaraderie of a group, a recovering fellowship, whether it be Alcohol Anonymous, Heroin Anonymous, Crystal Meth Anonymous, there's a million of them, those principles are very valuable. They should be any patient I ever take to, I always, that I talk to and I'm taking care of, I always talk to them about how this may be impactful in their recovery. There are many patients, being in active addiction is an isolating condition, and anytime you can be with community, that's bound to improve. However, and again, the different 12-step fellowships have trying to figure out, medicine changes. If anything, we've seen that in the last 2 years with the COVID-19 pandemic. I've never treated an illness where the rules were changing on a daily basis. And even in my short time period in this field, our approach to what's the best treatment for people who are affected by different substance use disorders has changed as well. The good thing is that we collect evidence, and we see when we want to make those goals, we want to keep people alive, we want to improve their overall sense of wellness, and then their contribution to their community and family, that we see that often medicines are very appropriate. That's tricky because before medicines were widely used, often it would be seen as replacing one thing for another, or That's the common thing. So I think what we see a lot is people who have had long-term recovery will say, well, I got better without it, why shouldn't you? And to be perfectly honest, that is kind of the opinion I had 15 years ago. I said, I don't get the point of giving a medicine to somebody who's already dependent on that medicine. The way I flipped it around is they're already dependent on that medicine, so we're not creating a problem. That ship sailed a long time ago from whatever exposure they had. What I'm doing is I'm improving their quality of life. I am definitely reducing the likelihood of death, which doesn't just affect that person, it affects everybody who has connection with them. And our overdose epidemic, it's not just opioids anymore, but our overdose epidemic has harmed communities, it's harmed families, and definitely has obviously harmed individuals. So anything we can do that we know from a scientific standpoint is going to improve quality of life and longevity of life, we should do. And I had a wise mentor who said to me, why would you want to withhold something that was going to improve their life just because maybe it wasn't available 10 years ago? That made perfect sense to me. So we think about medicines as only treating people with an opioid use disorder, but that's not true, because we use medicines to address tobacco. We use medicines and have for a long time to address alcohol, which are the two most devastating substances in our community. Tobacco and alcohol will rob the lives and disrupt families and communities much more than opioids or stimulants or marijuana ever will. But because they're legal, they don't get quite the attention. In my office, they get the attention because I don't want someone to stop using heroin and only die of lung cancer when they're 50 because I never address their tobacco use. A buzzword in people who treat substance use disorders and mental illness is, has been, at least for the last decade, is to reduce the stigma, which is true. One of the reasons that people don't get treatment for very curable illnesses, whether it be mental illness or substance use, or usually both, is the stigma associated with seeking treatment. We know that we have effective treatments and we can improve people's lives and can improve their impacts on their families and communities. I think even working in this field all day, every day with people who are impacted by mental illness and substance use disorders, I will have stigma and I will make prejudiced thoughts inside my head. I'm past the point of saying them out loud, but I definitely, especially when I get kind of worn down and taking care of lots of patients, because there's plenty for all of us to do. And I always go back to what a mentor told me a long time ago that said, when people are doing things that seem like they're causing more problems, know that inside their head that's not what's going on. They're not, and inside their head they're not causing more problems. Nobody wants to live that life. The problem is that most likely the pain that's associated with not using those substances is so great that they are picking the lesser of two horrible situations. I try as hard as I can to sit in the pain that my patients have undergone. I don't think I'll ever fully understand, but I do understand that substance use often is only because it's too hard to be without substances at that moment. And then so my job and my team's job is to make sure that, one, we acknowledge someone's trauma, we acknowledge that they weren't treated right, and that's something that I say all the time to people is I wish I could go undo what happened. Someone should have been looking out for you, someone should have treated you better, and a lot of times I might be the first person who's ever said that. And accept where they are right at that moment because of the impact that they've had throughout their whole life, whether they be 19, 29, 39, 49, 50. And we see patients who are 70 years old who are seeking help for the first time. Try to do everything we can to improve what we call the social determinants of health. It doesn't really help for me to write a prescription for medicines for someone who doesn't have any money to pay for them, or someone who to take care of them only to have them go back to an environment that doesn't support their recovery. And at all times applaud any positive change. Some buzzwords are things like harm reduction, and that gets everybody upset and saying, you know, why would you expect anything outside of abstinence? And I have to check myself that any positive change. So that means if someone comes to see me a year ago and they were using fentanyl 5 times a day and now they're using it once a week, that is a huge change. Are their drug tests going to be negative? Probably not. Are they still alive? That's a positive change. And then to start looking at things outside of these objective drug tests and say, you have developed a relationship with your family again, you are parenting your children, you're going to work, those kinds of things. And the patient gets to pick those, I don't get to pick them. But if they in their minds tell me I'm making progress, I'm achieving stability, then I will applaud that. If I was working really hard on something and someone came up to me and said, well, you didn't finish, so it's worthless, that would probably not help me stay fastidious towards my goal. So stigma, I think the words we use is a big deal. When I do interviews often for newspapers, I have to say words like alcoholic, addict, dirty drugs, dirty drug test, those kinds of things. We don't use those in any other medical illness. We should not label people by their illness, but instead it's a person with a substance use disorder. Someone has a positive drug test or an unhealthy drug test, they have a healthy drug test result or a negative drug test. And that's hard when, especially I work with people who've been in this field for 50 years, and to change your language and to watch and see the impact that it has when you do change your language is amazing, but to have a lot of grace with people as they learn and adopt a different vocabulary.